Let's move on to relapse disease, and we're all getting pretty comfortable now with daratumumab in this setting, but just to bring the audience up to speed, tell us about the studies that have been presented recently in daratumumab in relapsed myeloma, Ivan.
So, I mean, the two studies that were recently published in the New England Journal were the CASTOR and POLLUX trials, CASTOR being daratumumab, bortezomib, dex, and POLLUX with lenalidomide, daratumumab. And these studies were rather impressive. They showed a significant improvement in overall survival, progression-free survival, in patients getting the monoclonal antibody, as well as achievement of a significant number of these patients of MRD negativity. The thing that
no overall survival yet, right? Just PFS so far?
If I remember correctly, yeah. I think the thing that, in my opinion, is still somewhat of an issue that hasn't been resolved is how to integrate monoclonal antibodies that may also have an immune-mediated mechanism with regimens that may be slightly immunosuppressive, and specifically I'm referring to the combination of a monoclonal with a proteasome inhibitor.
Yeah.
And I think if you look at the difference between the control arm and the DVD versus RevDex versus DRD, I think that augmentation really speaks to the fact that there may in fact be some immune modulation that's occurring with daratumumab that is weakened when you come in with a proteasome inhibitor.
So the results of the daratumumab with lenalidomide looked a bit better than the
I think so, yes.
proteasome inhibitor.
Yes, and I think, I mean, at least our practice has been more to go in the direction of an IMiD as opposed to a proteasome inhibitor in combination with dara.
What about your practical experience of using daratumumab, side effects, infusion? How are you getting on with that, Saad?
I think, less than half of the patients get some degree of infusion reaction the first time around. For the most part, it's grade 1 and 2 and doesn't occur again with subsequent infusions. And the infusion time is usually about 6 to 7 hours the first time around, but can be cut down to about between 3 to 3.5 hours.
Wrong. You're exploring new routes of delivery, is that correct?
And that's correct. So we, along with other colleagues, are looking at a subcutaneous formulation of daratumumab. We presented the data at ASH. The overall response rates in a cohort of roughly 40-odd patients was fairly comparable to the IV formulation. There is a newer formulation, a premix formulation that we are examining right now.
We're only in clinical trials, right?
Only in clinical trials, not ready for prime time yet.
Other comments on daratumumab? Where are you, Tom, is this your go-to first relapse drug now, or are you still using carfilzomib, or both together? Where are you up to?
I mean, we still have a panacea of options in the first, especially the first relapse, and I think it ends up being a very long discussion with the patients, and convenience probably plays a big role here. So I tell them I would like to do a triplet therapy for most of the patients. We have all oral triplets, ixazomib, lenalidomide, dexamethasone. We have pomalidomide, Cytoxan, dexamethasone as orals. We have some IVs, elotuzumab, lenalidomide, dexamethasone, where the infusion rate is a little bit faster and it's less time in the clinic. And then we have daratumumab, which seems to give you the biggest bang for the buck. I would like to see what everybody else feels. In terms of the daratumumab, the infusion reactions, I give them steroids for the first 2 infusions. After that, my patients don't take day 2 or 3 dexamethasone at all, and I quickly taper off their pre-dexamethasone pre-med. So pretty much they're getting...
I think we've basically just used the same regimen each time. Yeah, that might be laziness more than anything.
Yeah. Except for maybe adding Montelukast as well for the first couple of doses, so days 1 and 8. For patients who have a reaction, we continue it in cycle 1 and then don't need pre-meds from cycle 2 onwards.
Same thing?
Yeah. Yeah.
There was an abstract here about, which I confess I'm not that up to speed on, but it's on cytogenetic risk in the studies. Is anybody familiar with that?
So I think there have been a couple of, there's both CASTOR and POLLUX data looking at subsets of patients, and it appears certainly with the len arm that the high risk treated with DARA did better than either the standard risk or the high risk without DARA. The difference between the curves was less in the bortezomib arm than it was with the len arm. But I think that that's actually, and I would disagree a little bit with what Yvonne says about the immunosuppressive effects of proteasome inhibitors. I think that what you're seeing, the reason why the PFS is so good with len is continuous therapy, as opposed to the bortezomib arm where they're not getting
And they
continuous
stopped
therapy.
in bortezomib after 9 months, right?
Right. So I think it's a continuous therapy versus non-continuous therapy arm. And I think that's what the difference is between why the curves are more disparate in the len arm than they are with the bortezomib arm.
So I thought the results of the control arm on the Castor study were not particularly good for bortezomib dexamethasone alone. And I must say, in my own practice, I'm not retreating with bortezomib that much. I am switching to carfilzomib. Is anybody, how often do you retreat with bortezomib, Sagar, again? Because you use a lot of it in your induction and maintenance.
Yeah, it's you know, for us, when somebody is progressing on len maintenance, our first salvage is to probably go to POM plus DARA, because you know the Pollux trial is hard to extrapolate, and the other choice is bortezomib plus DARA. I think that's sort of the decision point for us.
Okay, very good. And okay, I've lost my place here. Elotuzumab, you using much elotuzumab, Tom?
I use it in patients, honestly, that are more frail, and in patients that do not want to spend 6 hours in the infusion chair. And in that patient population, it actually works really well. When you get a nice response, and I'm curious to what Sagar says, and they say they have some lenalidomide-based toxicity, I continue them on elotuzumab alone. And I've had people, you know, continue to respond for quite some time on just elotuzumab alone.
Mm-hmm. Ivan, you using elotuzumab?
No, I haven't really used it much in the either maintenance or relapse setting.
And you're using a lot of daratumumab at relapse? Or?
We're using more daratumumab, yeah.
Okay,
So-
Saad, what about you? What's your...
I think that the only place that I can find for ELO, because it is an option, is that slow biochemical relapse in an elderly or frail patient, where you want to get, you know, you have luxury of time to see if this combination will help them or not before you move on to that next line of treatment. So that's where, you know, I would probably use it.
There's a sort of challenge with the sequencing. So I kind of wonder about the use of elotuzumab if you've already been exposed to daratumumab because of the cellular populations that get taken out.